right? So that's not really a zebra call. Like in this example, we know for sure one duoneb took care of things. So let's get back to reality. Can she sign a refusal now?
Yeah. I probably wouldn't suggest it.
Say again, please.
I wouldn't suggest it
Okay.
because she can go right back into it.
Yep. So what are some things that you might ask the patient that could help you decide if you're comfortable or not comfortable with letting a refusal?
We can just ask them basic, like history for last time they've had an asthma attack. Have they ever had to be intubated with asthma? Or,
Good. A couple.
Or how many rounds, or have you ever, like, how many rounds of medication do you use? Have you ever been hospitalized? Kind of.
All those are great. There's one more key one, beyond steroids.
Okay.
If somebody's chronically on steroids for asthma, I'm really going to try to push them in that direction. But if everything else checks out, it's probably okay to sign this. Can you have a, psychogenic's not the right word. Can you have a fear response that legitimately gives you a legitimate asthma attack out of fear?
Yes.
100% true. If you go to Netflix or Amazon, watch the movie Cape Fear, and this gal keeps getting the crap scared out of her by this guy stalking her and going into asthma attacks based off of fear. That's absolutely can cause a legitimate asthma event that you treat the normal ways. Okay. What would you expect to see if this was just simple hyperventilation? Because remember that slide said anxiety versus hyperventilation? What would the wave-form of benefit was that?
It would be low and tidal.
No. Yeah. No. I'm sorry. Yes. She's hyperventilating, so it would be low, and they'd be like this, with no plateau. Bronchoconstriction. So bronchoconstriction is what two things? COPD or asthma. You can't tell from looking at the device, so you got to use history. Wouldn't it be cool if there was a technology and a process where you could hit a button on your LifePak or your Zoll device that in 4 breaths you would like turn it and say hit asthma, and in 4 breaths the machine would make a decision about how critical they were. In 2002, when Dr. Krause came out, he was there for a couple days. He wanted to go on some calls with us, and he would hear us say code 1 or code 3. He's like, tell me what code 1 means. I'm like, well, that's non-emergency. Tell me what code 3 means. I'm like, emergency, lights and sirens. He goes, do firemen use that term more than green, yellow, red? I'm like, no one says green, yellow, red in the fire service. He goes, oh, I got to change my software. I'm like, what software? So he was working on software in 2002. You could turn the device, you would guess what it is, say asthma, and in 4 breaths the device predicts code 1, code 2, code 3. Predicts how critical they are. In other words, if this happens, this will move us from from reactive medicine to proactive medicine. I know we don't give Lasix anymore, but older medics, can you imagine ever giving Lasix to somebody with clear breath sounds? It doesn't even make sense in our world, but cardiologists do that all the time. They have more training than us, they know more things than us, but what if the machine could make decisions that we hadn't figured it out yet? And it could evaluate whether we were treating the right way or the wrong way. That technology, that software, has been in the subject of litigation for about 10 years. It's been out since 2002. I don't know if it'll ever make its way. And I used to say more about it, and he asked me to take it out of the presentation. COPD. So there's your shark fin appearance. Again, you would find out if it's asthma or emphysema based on the history. Okay, so this is important. The next 2 or 3 slides about asthma. Asthma can trick us. So earlier, in the very beginning, I said, what kind of patients, what would you think would happen in asthma? And everybody said shark fin appearance and a high number. That's not incorrect for a sick patient, but I want you to understand what's happened to the patient probably before we got there, or maybe while you were responding. So it turns out, in a mild asthma attack, because respirators go up, and tidal actually goes down. So if normal is 35 to 45, they're about here. They don't call 911 here. The only people that call 911 are new parents of a baby. And and they freak out. So we almost never see this scenario, but it happens. Anybody in here an asthma patient? Fire people never want to admit it because you're not supposed to have it for your SCBA. So everybody keep your little albuterol bulge in. So nobody calls 911 here. Now as they begin to tire, their breathing starts to drop down a little bit. So their end-tidal CO2 goes up a little bit. They probably call EMS here. Certainly they're taking hits of their net. And then if it gets severe, this number just keeps going up. The highest I've seen is 88. But anything above 55 should scare you. So that's true, but this next slide is what's really important, and we're going to talk about it. So, see how they say 50, 50, 50? Now see how they just changed? This is what's important to understand. Where you showed up in this patient's, and this is the same patient for this scenario, where you showed up in that scenario really, really matters. So, typically, we're going to take whatever the value is, let's put it in the middle, okay? So let's say EMS you get on scene and it's 50, and they're short of breath, and you give a duonap, and they're moving air. What would you expect the next end tidal to be if you're doing a good job and it's working? Would you expect it to go to 60, or would you expect it to go to 40? Or what would you hope? 40. You would hope that your care is already starting to move them back down to 35 to 45, right? But let's say that your care, same exact care, 5 minutes later they went to here. What do you think? Your care is probably not appropriate, not inappropriate, because we start everybody on doing EBS anyway. Now it's probably time to be taking out the epi. If it went from this to this, I'm not going to take out the epi. I'm heading in the right direction. So what matters in asthma is not the initial, it's what happens when you get involved with them. And remember, they may have also, especially with you guys with your quick response times, they may have just taken 3 hits of the inhaler. So you may get there and now it's that for you. And if it's this for you and you decide because they're still wheezing to give more, now it may be 50 and 30. What matters is what happens before and after your intervention. Got it? High numbers are still a bad thing. Quick scenario, I've got a couple of them left. So we've got two funny crystal stories, one involving gallium crystal. This particular one's a guy named Jared. He's a paramedic student, and in Oregon, you're not allowed to do your internship with your primary service or your primary county. They want you away, so you can't have any influence. Like no bro deals, help me out, sign me off on 4 intubations or whatever. So he goes to the next county away. This is in Woodburn, which has a small little bitty hospital, and they get a code. So they go to this code, and the initial end-tidal CO2 on this code is 34. He starts pushing drugs, shock, epi-shock, let-a-shock, bicarb shock, doing all the stuff that you do, and the 20 minutes into this code, and dead is still dead. So the patient's in asystole. So the preceptor says, okay, you ready to call the doc? He says, for what? To call the code. He goes, I don't want to call the code. What do you mean you don't want to call the code? I've got an end-tidal of 36 right now. He's like, but he's in asystole. And we've been coding him for 20 minutes. He goes, but I have an end-tidal of 36. He goes, so what do you want to do? He goes, I want us to transport. He goes, okay. Typical smart-ass fire service fashion. You're doing compressions all the way in. So they do compressions. Rampart Squad 51, coming in code 3 emergency traffic. Been coding a person 45 minutes in asystole. We've given it, he just gives the vomit box. End-tidal CO2 of 36. Do you have any questions? Nurse. No questions. Get to the hospital. During the transport time, a real code has also happened at the hospital. There's only one doc on at night. So that doc in the ER goes to work the real code. So in comes the crew. Jared's just dripping with sweat, riding the gurney. Comes in, they take him to recess. The nurse is just sitting there, charge nurse no less, and says, what are you guys doing? And he's like, the paramedic preceptor's like, paramedic student, go and give your report. So he does the whole report, and the nurse is like, stop, just stop, he's obviously dead. They were almost at an hour, they're like 52, 54 minutes, and this happens. Paramedic student, are you a physician? No. Is there a physician or a mid-level here? He's upstairs working the code. I'm not transferring care. May I use your drugs? And at this point, the paramedic preceptor's like, shit's getting real. This is gonna get good. This is gonna get good. So they move the patient over. The nurse wants nothing to do with this patient, but lets him use the drugs. So they can continue giving epi and bicarb and whatever. Doc comes down at minute 60 or 62, I can't remember now. And Jared gives his report. The doc's like, he's been in arrest for how long? She's like, an hour and a half. Still, no, but it's about an hour. Why are you still doing CPR? Well, now the entitle's 36, 37. Continue CPR. Continue CPR. I wish I could remember the drug that the doc administers. Oh, shit, I just don't remember it. And we're going to talk about this in just a sec. He orders four amps of bicarb. Boom, 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 boom. Put another one in the IV bag, and then run it wide open. Gets pulses back. Here's the part of the story that should make the hair stand up on your neck. When Jared crossed the stage for his paramedic pinning, the person who pinned him was the patient, neurologically intact. We didn't know this then, and there's been some studies to not suggest that this is valid now, but I think it was for this call. If you give sodium bicarb, which we don't talk about much anymore, and they're profoundly acidotic, and you give bicarb, you will see a big end tidal change. That doesn't necessarily mean you're going to get ROSC. It does mean they were profoundly acidotic. So think about that when you're giving your bicarb. Expect a little spike and then think, maybe I should give another one. Again, follow protocols. But that guy lived neurologically intact. He was in the nursing home for a mild stroke, but he was like, he walked onto stage and pinned. Everybody was bawling when he told the story. He talked about the scenario the whole 9 yards. Okay, turn the thing off.